welcome again to this online HTA course. This is the 6th video aiming to provide a brief introduction to the methods for economic evaluation. Up to now, you learn about the cost, you learn about the effect, you learn how to summarize the cost and the effect, but we have not yet really discussed how to conduct an economic evaluation. And this is what we plan in this next video, to really provide some background on the methods for economic evaluation. There are two main methods for conducting an economic evaluation: a trial-based economic evaluation or a model-based economic evaluation. In a trial-based economic evaluation, as mentioned in the name, we have a clinical trial and we collect economic data alongside the clinical trial. So, for example, we have two treatment A and the comparator treatment. We have our patient and we will collect the cost of each of our patients in the trial with a cost questionnaire, and we will also collect some utility, by example, with the EQ5D questionnaire. And based on this questionnaire in the trial, we will estimate the cost and the quality of every individual patient. We then take the average of the group and we could estimate, apply the formula of the incremental cost effectiveness ratio. Then a kind of easy way to build up an economic evaluation by collecting cost and effect during the trial. There are some advantages of this approach. First is the high validity, because you collect the cost, the effect, and the utilities in the same population. A trial-based economic evaluation is also an early opportunity to produce cost-effectiveness results. Based on the trial, you could simulate what could be the potential cost-effectiveness, and you really use individual patient data. There are, however, some disadvantages of a trial-based economic evaluation, or some limitation. The first is the truncated time horizon. In a trial-based economic evaluation, you only collect the cost and the consequences for the duration of your trial. If your trial lasts 1 year, you just collect the cost and the outcome for 1 year. But sometimes preventing one event, preventing one cancer, by example, also lead to benefits in the future that cannot be captured with a trial-based economic evaluation. This is one limitation. Another limitation is the limited comparators. If you do a trial-based economic evaluation, you can only compare the intervention to the comparator of the trial. But maybe there are other interventions that could be relevant for policymakers, and that would also be needed in a fair comparison of all alternative options. Another potential limitation is the restricted generalizability to different settings, because you just base on one trial that has maybe a really specific setting. And another potential limitation is the failure to incorporate all relevant evidence, because you just base your economic evaluation on one single trial and then not on maybe other data or other trials that are available. But the usefulness of trial-based economic evaluation really depends on the research question and on the population. In some cases, it is really an appropriate method, especially when there is no long-term consequences of the intervention. And even if we conduct a model later, a trial is really needed to get some economic data and to get some effectiveness data or efficacy data regarding your intervention. There are a lot of recommendations to build up a trial-based economic evaluation, and one key missing aspect is the handling of missing data in a trial-based economic evaluation. And there are some recommendations. By example, how it is important for people involved in a trial-based economic evaluation to really try to maximize the response rate. And this article that you could find in the course manual provides some of the recommendations what to do to really improve the collection of data and to prevent missing data. Further, there are some recommendations what to do when there are some missing data. For example, we can use multiple imputation methods. Some sensitivity analysis also needs to be done when having missing data. And the reporting of missing data is also something important with a lot of recommendation. Because if you are involved in a trial-based economic evaluation, this type of recommendation can be really useful. Thus, trial-based economic evaluation is one method to conduct an economic evaluation. The other method is more the use of model-based economic evaluation that we also call decision analytic modeling. And thus, we use mathematical models to synthesize all available information regarding healthcare process. Thus, a model can be used to predict the cost and the health outcome of an intervention. And interestingly, beyond the scope of available evidence, we can really extrapolate the benefit from a trial over the long term to really capture the long-term consequences of the intervention. In addition, with a model, we could really compare different interventions and also interventions that are not directly compared in a trial. We do indirect comparison. And a model can also generalize results to other settings. And the models are most commonly used really to inform about efficient resource allocation. Some advantages of modeling. It allows to compare all feasible and all relevant interventions. It explores the full range of clinical policy questions in all populations and in all aspects. It's something done for a full range of patient subgroups. You can really identify in each subgroup the cost effectiveness of the intervention. It also allows to systematically combine evidence from different sources, and we can combine data, efficacy data from different trials. And finally, it extends results from clinical trial over the long term to really capture the long-term benefit of intervention. But there are also some challenges, some difficulties with decision analytic modeling. A first limitation that policymakers can do is the lack of transparency. We really need to be transparent in the manner our model is built. Another potential limitation is the quality of data and of the model. Model-based economic evaluation is only reliable if we have good data and if we have a good model. And we know there are some potential limitations in the build-up of a model. Parameter uncertainty is another limitation. There are some uncertainty in the parameter we use, in the way we build up our model. And that's also why we conduct, as you learned before, some sensitivity analysis. And finally, there are also some limitations if we make some indirect comparison between treatment. Just be aware that the model is something that has a lot of advantages, but we need a good validation and a good building up of the economic model. Just some further information about the stages to develop a decision model. First, you need to specify the decision problem. What is the question to be addressed? What is the population? What are the interventions of interest? Based on this decision problem, you define the boundaries of your model. A model is a representation of the reality, a representation of the healthcare process, but a representation is only a simplified version of the reality. Then you should really think, what are the options, what are the consequences, and what are the boundaries of your model? And then the next step is really to structure your decision model. What are the possible consequences? What are the options within your model? You really build up your model. And in parallel, and also later, you really need to identify and to synthesize the evidence. Try to find the best possible data for every parameter, for the events rate, for the effectiveness, for the utilities, and the cost. And the last step is to deal with uncertainty and with heterogeneity with uncertainty analysis. To conceptualize the economic model, thus we really start with, we have the reality. That's the healthcare decision process. And you try to build up a model to conceptualize the problem. Thus, you need to really have a model representative of the decision and the problem and of the disease. And then you will really conceptualize the model with the data that are available, and you will build up a model. And the type of model will depend on the specificity of your intervention. And based on your model, you will get some output that could be used to inform policymakers about the cost effectiveness of the intervention. A decision analytic modeling, a decision model, is just a quantitative approach to decision maker under uncertainty. And with a model, you estimate a series of events, like, by example, having a stroke. That's a typical example of an event. And for each event, you will get some cost and some outcome. This each event is associated with cost and outcome, and we need some probabilities for each of the events. Then some key aspects of a model are the events, the cost, outcome associated with the event, and the probabilities to get specific events. The model that we use in a model-based economic evaluation should match the conceptual model. And there are different types of models that we are using in health economic evaluation. The most simple model is a decision tree that I will explain in the next slide. Another more common type is the use of state transition model, like Markov model, which are really common in our research. And other type of model include discrete event simulation, where we really simulate the time to event data and we really record individual experience. And another type of model is the use of dynamic transmission model, especially in infectious disease. The last two models will not be explained in this course, but there are a lot of guidelines in the literature and recommendation. To build up a model, we just have a lot of data. We need a lot of data. For example, for the rate of the event, typically based on observational studies or trial. We need data on the treatment effect, and we typically use trial data or observational studies. We also need data for the long-term prognosis of the disease, typically based on the longitudinal observational studies. And we need cost data for the resource use and utilities also from observational or cross-sectional studies. And what is really important when building up a model is to really use evidence-based medicine and to use the best available data. And sometimes we need to conduct a systematic review or a meta-analysis to really build up the best possible data for your economic model. Some explanation of a decision tree. That's the more simple way to build up an economic model. In a decision tree, you have decision node, probability node, and terminal node. Thus, first, we have a decision node because we have to choose between two treatments, treatment A and treatment B. Then we have the probability node because we have some probability to get a side effect or to not get a side effect. And the probability to get a side effect with A is not the same as the probability to get a side effect with the treatment B. And then at the end, we have the terminal node, we have a cost and quality associated with having side effect or having no side effect. And based on the probability of each event, we could simulate and estimate the total cost and the total quality of each intervention. That's just the cost at the end multiplied by the probability to be at each of the events. And this type of model is really simple to conceptualize, to create and to modify, but one main limitation is that we have no explicit representation of time. It's really something for the short term, not really appropriate for the recurrence of the events. And that's also why this type of model is not commonly used in health economic evaluation, because often we need a long-term period and we have a kind of recurrence of potential event, especially in chronic disease. But it's a type of approach, simple, that could be attractive in some situations. The most common type of model we use in health economic evaluation is a Markov model. In a Markov model, we have different health states. So, for example, on this slide, you see that you have 5 health states. It can be clinically unaffected, mild dilated cardiomyopathy, dilated cardiomyopathy, implantable cardioverter defibrillator therapy, or death. Thus, the patients are divided into different health states, and the patient will progress through the health states over time based on probabilities. And thus, with a Markov model, we need to define the length of a cycle, the length before moving. So, by example, if we have a 1-year cycle length, every year we have a probability to move from one health state to another. And again, in a model, probabilities are important, and the cost and the health outcome are associated with the time spent in the different states. So, by example, we need a cost and a utility for every L state. And thus, for one intervention, we will follow each individual patient over time. A patient could, by example, move from this L state to this one, stay 10 years in this one, then 2 years, and then you will just sum up the cost and the utilities in every cycle. And you did it for one patient and then for thousands of patients, and then you get the average cost of your intervention. You do it for the intervention A, you do it for the intervention B, and then you get total cost, total quality that are different because the probabilities are different, maybe the cost of treatment are different, and leading then to different total cost and quality, and making possible the estimation of the cost effectiveness ratio of the intervention. This type of model, the Markov model, that we also call the state transition model, are simple to develop, to debug, to communicate, and to analyze, and they really involve this homogeneous health state with different characteristics. And thus they are really appropriate for chronic disease when we need to model over the long time. A main limitation, at least of a cohort analysis, is the Markovian assumption. This is also called the memoryless. It means that when a patient is in a specific health state, we do not really know the past of this patient, and we cannot modify the probabilities or the cost based on the history of this patient. However, there are some techniques available, for example, the use of tunnel states or microsimulation model that really allow to take the history of the patient into account. And some more advanced Markov model, like macrosimulation Markov model, are available to better characterize what we have in real life. And a lot of recommendations are available in the literature. Some aspects important in model selection. Something important is the time horizon and the time measurement that will really influence the selection of a model. We can only select a decision tree, by example, if we have a short time horizon. For the choice of a model, it also depends if we need to model individual patients or at the group level. If the history and the memory is something really important, we will go more for a macro simulation model, like a macro simulation Markov model, or maybe a discrete event simulation. It's also important to know whether there are some interaction between individuals and model components. Something key in model simplicity is important for the transparency, for the ease of the analysis, for the validation, but a model should also be complex enough to represent the complexity of the real. That's a bit the challenge. You should have an easy model and transparent to have a good explanation, but also a sufficiently complex model to have a good representation of the real life. And something really important when building up a model is really to involve clinicians. Clinicians should really be involved in this decision. They should really help the health economic modeler with providing some input on the assumption or the model to really have a good model. And that's why to build up such model, there are some health economics modelers together with clinicians. Building up a model is a long process, and there are a lot of steps. I will just give you some guidelines to build up some model. And model validation is something also really important. And there are different types of validation: internal, external validation, cross-model validation. That will not be explained in the course, but a lot of references are available to get more information. Regarding the guideline for economic evaluation, a lot of example, by example from the BMG journal, another guideline for model-based economic evaluation, another one also for modeling good research practice, very well known from a working group of the ISPOR and the SMDM. Another one is more focused on trial-based economic evaluation. There is another one also done by one of the speakers today a few years ago, a kind of checklist to assess the quality of economic evaluation. And recently was also just published a checklist for the reporting of economic evaluation. Thus, there were a lot of support available to make a good economic model. Regarding this CHEERS 2022, it is just a checklist to report economic evaluation, and it provides 28 items that you should describe when you report an economic evaluation. And some of them are for the abstract, some of them are for the introduction, some of them are for the method, for example, regarding study population, the setting, the comparator, some of them for the result section or for the discussion. Then a lot of criteria that needs to be reported when you report on economic evaluation. In addition to general guidelines for economic evaluation, there are also some disease-specific guidelines for economic evaluation that provide some recommendations really specific to the disease. And there are also national guidelines for economic evaluation. For example, there is a Dutch guideline for economic evaluation in healthcare. And thus any researcher or industry that conducts an economic evaluation in the Netherlands should follow this guideline. That is something really important to follow when you build up an economic evaluation. And in the Netherlands, we also have a reference price for the cost within the healthcare sector. As also explained in another video, that's also part of the Dutch guideline for economic evaluation. And some further reference on this topic that you could also find in the course manual. Thank you for listening.